Our next speaker, last night we went to the ball game and I turned around and there was this lady with a big toque and a big hat and a big coat. And that was Martha Nolan. I met her. I was warm. She was warm. She was a warm one. Anyway, Martha Nolan is Vice President of Policy for the Society of Women's Health Research in Washington. The Society for Women's Health Research is the thought leader in research on biological differences in disease. It is dedicated to transforming women's health through science, advocacy, and education. Ms. Nolan, a lawyer and a lobbyist, advocates for greater funding for women's health research and advancements of public health gender policy at the United States Congress, the NIH, and the FDA. She is the former Assistant Vice President of Federal Affairs at MetLife and lobbied for the successful passage of the Federal Employee Long-Term Care Insurance Act. She chaired the Disability Insurance Industry Technical Advisory Group before the Social Security Administration and co-chaired the Disability Discussion Group. So clearly, Martha is going to present a different aspect of this whole issue compared to our three previous speakers. So please join me in welcoming Ms. Martha Nolan.
I don't know how actors do it on stage. It's blinding up here. Anyway, thank you for inviting me to speak today. I really appreciate Pregmedic inviting me and also the sponsors of the organization, this huge meeting. And I'm delighted that all of you are still here in this room to hear me speak about gender barriers in policy and regulation, basically in the United States, even though I know that we have a tendency to then be followed by the rest of the world. So as has been said, I represent a Washington, D.C. based organization that advocates and has advocated successfully regarding the inclusion of women in researching of women in clinical trials, even though Gideon has somewhat indicated that there are problems. For over the last 2 decades, the Society for Women's Health Research, which I'll refer to as SWHR, has been a driving force behind ensuring that biomedical research is being conducted on women and raising awareness of the fact that there are many unique biological and physiological differences between men and women. Today, we regularly speak about women's health or men's health and sex and gender differences, but that was not the case even till recently. You still may surprise many in the room that until 1990, the scientists believed that men and women were biologically the same except for our reproductive capabilities. As is now known but was not sufficiently understood by all physicians, there are many conditions that affect women solely, predominantly, and differently from men. Enormous scientific advances have been gained in the last 20 years since the advent of the 1993 mandate on the NIH, that was advocated by us, actually, in front of Congress, to include women and minorities in clinical trials, and the lifting of the prohibition by the Food and Drug Administration prohibiting women of reproductive years in clinical research. But despite these legal and scientific advances, gender barriers in biomedical research policy and regulation unfortunately still exist today, and I'm not even referring to the unique challenges that you all are trying to address regarding pregnant women. And I believe Gideon and many others have demonstrated these barriers today. But it is very important to understand what it took to accomplish the first change and the incremental steps since then to be able to frame what it might take to change policy and remove barriers regarding studying pregnant women. What is interesting about this opportunity to speak today, and I thought about, is that it began back in 1988 with a question. And you're asking today a question regarding researching pregnant women, as there is a tremendous need in medical research to treat women who become sick during pregnancy or are sick and become pregnant. The question that was triggered back in '88 was caused by the Physicians' Health Study. So I don't know if some of you understand the history of what actually happened and how we suddenly discovered that women weren't being studied. As there was this huge media outcry, hoopla about taking an aspirin a day if you have a risk of heart disease. Well, the question that many women and physicians ask, well, is that true for women? This is a simple question that caused quite a stir, as no women were in the study. It was 22,000 male physicians. The answer is no. aspirin does not work as well for women with heart disease. However, women didn't get this answer for nearly 20 years in 2005. It is now known, for example, that heart disease is the #1 killer of women, though women and men differ in their presenting symptoms of heart attack, confusing diagnosis and treatment. Unfortunately, disparities in diagnosis continue to this day, often leading to underdiagnosis, improper or less aggressive treatment, and resulting in worse outcomes than should be the norm. And this is for a disease that we actually do study in women. Until recently, women generally did not know that there were important differences about their health from men, and that possibly they were not getting the right diagnosis and treatment. Many still don't, though we are still trying to change that. And obviously the same question will be true for pregnant women. Most pregnant women and those considering pregnancy and postpartum are not aware of how little research has been done with respect to their condition, if you want to call pregnancy a condition, and that the medicines they're taking have not been studied on them. It is a simple question that she may ask while pregnant: has this been tested on someone that's like me? That she discovers the truth and the tough decisions that healthcare practitioners now face. I am thankful, I'll give you an example, I'm thankful that I didn't face this during pregnancy, but I did face it shortly after giving birth, and when I was in the emergency room for a very bad case of pneumonia 2 months after giving birth. The question that was asked was whether or not, since I was breastfeeding, between the ER doc and my internal doc, as to whether or not this drug they were going to give me was going to be safe for the baby. Now, trust me, when you're in that condition, you're sort of hearing things, but you're not paying attention because you're in a lot of pain. But I did ask, and I had no idea at the time how little they knew. Obviously, I came out fine, but it's just reflecting and giving the talk today made me think back on that experience. Obviously, this needs to change, and this needs to change even for women who are healthy, as opposed to, women are healthy. Women who are facing regular diseases as opposed to those that are actually pregnant. We need to know more. There are major policy barriers that SWHR faced 20 years ago, and one of the fundamental ones that they would need to change was the inclusion of women in trials, as well as the prohibition by the FDA in 1997, again, not allowing women to be studied during their reproductive years. In addition, we also faced, it was documented, this was useful, that it was well documented during our advocacy efforts. It was easier for scientists to study men and women and extrapolate the data, as women are expensive and costly to include in trials due to their hormonal cycles. That was actually stated in the media. This was openly revealed, though I admit to simplifying the argument by making that statement. The NIH did not include women in clinical trials, even though in 1985 the U.S. Public Health Service Task Force reported that the lack of research on women had compromised the quality of information and care for women. So when the Aspirin study came out, there was a dedicated group of scientists led by Dr. Florence Hazeltine from NIH and other advocates, providers, and patients. They came together around that question. They created the advocacy organization. So SWHR knew that in order to be able to succeed in changing attitudes and policy, it would need to be a broad-based group. They were able to pull together physicians and researchers specializing in cardiology, mental health, obstetrics and gynecology, as well as many others, and then also nurses, lawyers, and public policy advocates, men and women. And this will be true today in order to change pregnancy policy. So I'm going to go through some of the steps that we took to try and gain the changes back in the early 90s, and what will probably need to be taking place today. We had to seek the support to get media attention and greater visibility of the issue. We sought the help of Congressional Caucus on Women's Issues, made up of women members of Congress, as well as some powerful male members of Congress, to demand hearings as well as a government accountability office investigation. And we asked that these have to be requested by members of Congress, and it helps to investigate a particular issue, in this case, NIH's policies and practice regarding the inclusion of women and minorities in clinical trials. This is a key step because basically, once the report comes out, the federal agencies have a tendency to pay attention to them as they know they will be called before hearings to answer the questions raised. The timing did work for us, because there were hearings scheduled in the NIH, on the NIH, and the report came out at the same time. That's not always worked that way. And basically, the report did conclude that the NIH policy towards the inclusion of women in clinical trials had not been well communicated or understood or enforced within the NIH or the research community. It was applied inconsistently across institutes and was only applied to extramural research, if at all. I do recognize the vast majority of NIH research is not in clinical research. It's more basic. So these dramatic hearings created quite a media outrage. I have all the coverage in our historical files. It was really quite impressive. And the end result is NIH felt pressure, and it tried to change its internal policy guidelines regarding women and minorities being included in research and establish the Office of Research on Women's Health. But as many of you know, these are words on paper and not much changed at NIH. And so the end result is we knew that we would need further action by Congress. And in 1993, the opportunity came to have a mandate by Congress through a certain legislative vehicle. In this case, it's the reauthorization of the various federal agencies. Again, I'll explain that, but back in 1993, unlike the dysfunction today, Congress actually did regularly take action and review agency statutes. And doing that process, it sometimes redirects or eliminates the responsibilities, the focus, the priorities of an agency. They do this carefully because in opening up a statute, it opens up the opportunity for people to suggest changes through amendments and other proposals. And it takes time and it have to be a certain control over the process. But it is an opportunity to make change. And we took that opportunity in 1993 and advocated successfully for Congress to mandate that NIH will include women in all phases of clinical trial, and in particular to some of the discussion today that in phase 3 clinical trials, there be sufficient numbers of women to be able to analyze by sex, and then wonderfully permanently authorize the Office of Women's Research on Women's Health, which, as you also have heard, has been engaged in making sure that research is done on women and sex and gender differences research. We also, that same year, turned our attention to the FDA as knowing that that was our other barrier and had another GAO, the Government Accountability Office, investigation of that agency as they have a greater impact on clinical research. Not surprisingly, they reported that the women were underrepresented in drug trials, and even if women were included, data were not analyzed to determine if women's responses to drugs differed from those of men. And insufficient numbers of women were not included in pre-approval clinical drug trials. And obviously, they encouraged the FDA to improve female representation. This did result in the FDA issuing guidelines that same year and removing the prohibition of women being included in clinical trials and requiring the analysis of data on sex differences as well as those of race and ethnicity. I'll come back to that because that's a key point of what happened last year in our efforts. Well, these exciting changes to federal law and regulation and guidance really did break down the barriers for women's health research, but I will tell you that actual policy and practice didn't change overnight. And it has taken us the better part of the last 20 years to try and make scientific community understand that studying women is important and that medical practice needs to apply the changes we're learning in research more quickly. We've had to hold scientific meetings across the country, and we do more regularly now with a conference called What's the Difference an X Makes. We also helped create a scientific research networks on sex differences. We've established the Scientific Society, the Organization for Study of Sex Differences, and I know one of our former presidents is here, Virginia Miller. And there's also a scientific journal, The Biology of Sex Differences. Again, trying to keep the pressure on. We have attained congressional funding when they used to allow earmarks for, as we know that's a bad word now, directed to the various offices of women's health, and particularly for the Office of Research on Women's Health, earmarked for the Birch program, which is building interdisciplinary research careers on women's health, which has been an incredibly successful program. We utilized various other means as well, including the Institute of Medicine, and we helped fund a broad scientific groundbreaking report exploring the biological contributions to human health. Does sex matter? Yes was the answer from bed to bedside. And I will tell you, this report has been widely utilized since to fight for women's health and sex differences research. It validated it, and it still validates it to this day. We've had to go back to Congress several times since to try and keep the pressure on the agencies. We've had further GAO reports. Investigations resulted in reports on the NIH and on FDA, where the results of the reports keeping pressure has indicated that not enough progress had been made, particularly at NIH, on women's health. This was about a decade ago, and I know that transformations have happened since. As was noted by Gideon, there has been a report on the FDA that the 8 out of 10 drugs withdrawn had worse side effects on women, which we've also used in arguing toward trying to transform the FDA in inclusion of the reporting and analysis of sex differences. Wonderfully, a 2010 IOM report on women's health, which was had barriers. Actually, I don't remember the exact title of it, but it was on the advances in research on women's health. One of its recommendations, very clearly, was to the FDA to enforce its own regulations and guidelines with respect to reporting and analysis of sex, race, and ethnicity. The irony of this report, in terms of timing and trying to change policy and regulation, is that we were up in front of Congress trying to get them to include within the huge FDA bill, which happens every 5 years through the user fee process. In the user fee process is where the drug industry and the biological industry and now the generics and so forth pay user fees for the regulatory process to help speed along the process faster than it had been to date. I'm simplifying that. It's actually far more complex than that. But they reach an agreement, and it becomes a piece of legislation that has to be passed by Congress every 5 years. We were trying to include a very important piece of legislation to keep the pressure on the agency to actually enforce its own regulations and guidelines. And ironically, having to present in front of the Senate committee that has authorization over that, not only over the FDA, but over that piece of legislation, they argued that our data was old and there was no current government report that proved the fact that the agency wasn't enforcing its own guidelines and regulations. And a month later, the IOM came out with its report. So it delayed us in being able to include it in that year, but we did succeed the next year. Again, we now have that report. We had the information, and I really could have used Gideon's presentation, would have sped up the discussion. I have to admit that, that the FDA needed to do what it had said it would do in guidelines and regulations. Guidelines, unfortunately, do not have the force of law. They're just a suggestion. As Gideon said, you must attempt to include women. And regulations have far greater impact, though they are harder to get through. So I'm going to further explain that that effort regarding the FDA has resulted in the fact that we now, in the user fee law passed last year, includes a section. It's hundreds of pages long, but in there is Section 907, which actually is a mandate on the FDA that they have to issue a report and they have to make it publicly available regarding demographic data that is submitted to the agency and provide how they're doing the analysis of the demographic data. While I'm not entirely sure now how that report will come out because it's not going to be published until July of this year, it is an important step forward and perhaps will address some of what Gideon was talking about in terms of making the agency delve into the data that it has had and had for a while but hasn't done anything with it, and how that will then domino effect back into industry and change how they report the data and what analysis they do. We are hoping will start changing a lot of that information regarding women, let alone pregnant women. So regarding policy on pregnant women, I was thinking about how to approach the discussion today in terms of changing policy on research on pregnant women when we still have a challenge, as you have heard, regarding studying of women in general. I recognize that you are still working on a presumption from 1994, which is an IOM Institute of Medicine report, that created the presumption of exclusion of pregnant women, and further, that there is no requirement for justification for that exclusion. And that would be one of the things that would need to be addressed. There also are several major regulations and guidelines that continue to govern the landscape regarding researching pregnant women, though there are others. I'll just talk about two of them. The FDA in 2004 issued its pharmacokinetics and pregnancy guidelines, and those are still the guiding principles for the community. But they also still lead to a persistent presumption of the exclusion of pregnant women from clinical research. But I do understand, and I'm not sure if you're aware, that they are developing guidance now to address the ethical and scientific complexities associated with studying pregnant women in the setting of a clinical trial. I don't know where it is in the process. I wasn't able to get that information from the FDA, even though I asked them on Friday. They can be very revealing. But I do think that once we have an opportunity to comment on it, we all should. It's very important that we all weigh in and provide that agency with whatever information we can. They do listen. Then there's also the Code of Federal Regulations on Human Subject Protections, in particular 45 CFR, 46 subpart B, there's the lawyer side of me coming out, places the burden of inclusion quite high for inclusion of pregnant women, and basically requiring that if you're going to include the pregnant women or fetuses, they really must meet all the 10 conditions that are outlined. I'm not going to list them because that would take up way too much time, but to put it simply, clinical research in pregnancy can only be conducted if there's direct benefit to the fetus or mother. Otherwise, the regulations prohibit research that is more than minimal risk to the fetus. And the definition of minimal risk is vague, leading to major barriers to being able to proceed. And also, the irony of this is that these are laws and regulations that are intended to provide clarity, and the end result is they haven't. The 10 requirements are subject to incredible interpretation, differences of opinion, and typically determined rather conservatively by IRBs, and then the IRBs do not apply them consistently across the states. But efforts to address the legal and regulatory barriers in pregnant women in clinical research are happening. Recently, I was asked by ACOG and several other physician organizations to work together on a congressional efforts to help transform pregnancy research policy. In this instance, ACOG is seeking support for a proposed congressional resolution in favor of the inclusion, and such resolutions are helpful to test the waters and interest and resolve of Congress to go farther in actually changing laws or to put pressure on agencies. And I'll tell you, what helps propel our congressional efforts is the fact that the scientific community has provided strong support and recommendations to call upon. And I think some of you are aware that in 2010, the NIH Office of Research on Women's Health convened a very important scientific meeting, Issues in Clinical Research Enrolling Pregnant Women, and which was in partnership with various institutes and centers and the FDA and so forth, to address ethical and IRB and recruitment issues that investigators face in clinical research studies that enroll pregnant women. Now, while for many of you it provided a forum to present challenges and strategies to overcome those barriers in clinical research, for us advocates it provided solid evidence for policy change and specific recommendations and clear, broad support of the community. Another major effort is the Second Wave Initiative at Georgetown University, and I don't mean to not mention many others, but particularly struck me. The first wave, of course, was the one the Society endeavored 20 years ago. So the second wave is endeavoring to address that presumption of exclusion of women from research that has led to the troubling lack of knowledge. These two efforts, among many others, are aligning important voices and stakeholders that we advocates and lobbyists cannot change legal and regulatory policy without. Because in order to be able to convince lawmakers, we're going to need the data and the reports to help them over the protective hurdle for pregnant women. Because getting regulations and guidance issued, as you see, it takes a very long time, can be rather difficult. So what I want to say in terms of time, the effort that we did with the FDA started in 2005 with respect to the data reporting by the FDA on sex, race, and ethnicity, enforcing their own guidelines and regulations, expanding it to be to drugs, biologics, and devices. And it was in basically July of 2012 that we were successful in including that a particular provision in a bigger bill, vastly rewritten, mind you, but still it took those several cycles of Congress to be able to get that far, and also a great deal of due diligence with members of Congress to do that, and also recognized that when we went to, in the final stages of that bill to get it through, industry and the FDA came at us with both barrels to prevent this provision from being in the bill, claiming that it was not necessary, that they were doing this research and analysis. And it was useful to be able to get leadership in the Senate, ourselves and our data together, to be able to have this major meeting prior to the inclusion of that provision. And we were successful. It was very exciting. But it can be rather nerve-wracking, as you can only imagine. So, I'm not sure if I've gone over my time, but so in thinking about how you would try and face this, I think that there are obviously going to be needing to be changes at FDA. You're going to need to change that presumption. There are opportunities to do so. As I said, there is a guideline, that they're working on. I do not believe they're working on any regulation. There could be a request for them to consider regulation that may require a number of meetings to do so. There's also the HHS, which recently in 2011 is asked for input on the common rule regarding human subject research. Now, what was interesting about the fact that they recognized that the regulations needed to keep pace with the clinical research and the fact that there's now multi-site clinical trials and observational studies, they did not ask about Subpart B, which needs to change, and it basically needs to be addressed, but they did not ask for that particular section, and that was noted in some of the comments that went into the agency, and perhaps a special working group needs to be brought together to have HHS address it, and that's another area where consideration might be given. So I feel that the effort to bring this all together is going to require more than the scientists. It really will require also bringing in the lawyers, because I think litigation is a huge issue with respect to pregnant women. I know that I believe some of your institutions, and certainly the IRBs, bring up some of the liability issues and the concerns in making sure that protections are there. I think at any policy change that will likely come up, and it will need to be addressed in a reasonable fashion if that's possible, as that is the pervasive fear of litigation. The pervasive fear is probably what drives the conservative policies and practices. So in thinking about the changes, obviously there are changes to the government guidelines that need to be changed at FDA, NIH, even the IOM. I know there's a proposal for women that should no longer be considered a vulnerable population. That's the language that's in our guidelines, and perhaps be considered a complex. I know we are complex. I think anybody who's married wouldn't argue about that. But the fact is, vulnerability is certainly a loaded legal term, and complex doesn't carry that same loaded nature to it. I know that there obviously needs to be consideration of a lot of discussion with the IRBs regarding the inconsistencies across the states and how that might be addressed, since there's a far greater number of multi-state clinical trials that cover different states, and that creates a great deal of inconsistency. Informed consent will have to be addressed as well. I do believe pregnant women, as any woman, can make a decision and are capable of understanding it. Obviously, and a couple other things that I also don't know whether you're aware of, that in the user fee law last year, there was the patient advocacy groups were very successful in inserting language regarding the need for the patient perspective, especially on benefit and risk, and including the patient's disease focus in terms of the clinical trial design. And that has resulted in the law requires meetings with the FDA, with patient stakeholders, as well as the industry regarding various diseases. And I know that it's in its infancy, and the agency is endeavoring to try and figure it out as much as any of the rest of us, having attended many of the process meetings, as well as now the first meeting is actually next week. And I just remember chronic fatigue syndrome is one of the studies on Thursday and Friday of next week. The reality is they are taking into consideration the issues that patients face in designing the trial and what the outcomes are, and what does the patient really experience and really care about in designing the actual research. And this is new for the agency. I don't say that they haven't ever considered it, but certainly our engagement and our involvement in the process is new and it's exciting, and I do think that it can apply in the area of pregnancy and respect to the risk and benefit discussion. There also were changes to the REMS process, the risk evaluation mitigation strategies. They were endeavoring to change them to have them be more workable. I do think in there is a great opportunity to, since a great deal of these drugs are used off-label, for the FDA to increase the information that it demands regarding the use in pregnant women. And also exposure registries. I don't know as much about them and how they are set up, but I don't know that we have them set up in a way that truly captures all the data that's available, nor do I feel that we, as a community, the medical community and the science community combined, work closely enough on the pregnant women to ask any and all pregnant women in medical practices to collect data regarding our experiences. I think there's a great deal of information that can be learned, and we don't often ask enough women whether or not they're willing to be studied and for how long. So I really look forward to working with all of you and with many other organizations in Washington to try and come together and address these major issues. There are many thousands of pregnant women, hundreds of thousands of pregnant women in the United States and in Canada and elsewhere in the world that definitely need a change to how our policies and regulations are currently set up. So I look forward to it, and I thank you for the opportunity to speak today.